name is John Magana, and I am a fourth-year medical student at the Sidney Kimmel Medical College at Thomas Jefferson University, and I will be presenting this case report on a patient with scleroderma. This case was prepared under the guidance of Dr. Russell Reeves. This patient is a 61-year-old female with a past medical history of interstitial lung disease who presented to the emergency room with worsening pain in her joints as well as lower extremity muscular pain and weakness. She was afebrile with a heart rate of 104, blood pressure of 130/75, a respiration rate of 19, and oxygen saturation of 97% on room air. On physical exam, telangiectasias were present. She was also noted to have decreased skin turgor with diffuse skin tightening. Bilateral finger deformities, possibly clubbing, were also noted, as well as decreased range of motion in the fingers. Other diagnostic testing was positive for an elevated erythrocyte sedimentation rate at 65 millimeters per hour. Her serum calcium was at 9.2 milligrams per deciliter, which is within the normal range. Her serum parathyroid hormone was at 36 picograms per milliliter, which is also within the normal range. The image on the left is a magnified radiograph of the right hand showing bony resorption of the tufts of the phalanges visible at the 2nd through 5th fingers, denoted by the blue arrow. The bones are diffusely demineralized with more pronounced bone loss and a periarticular distribution. An example of this is pointed to by the white arrow. In the middle is a PA radiograph of the right hand showing soft tissue calcification involving the tip of the first digit, shown by the yellow arrow. There is bony resorption of the tufts of the phalanges visible at the 2nd through 5th fingers, again shown by the blue arrow. Calcification throughout the carpal joints can also be seen, denoted by the white arrow in this image. The bones are again diffusely demineralized with more pronounced bone loss and a periarticular distribution. On the right is a lateral radiograph of the right hand showing soft tissue calcification involving the tip of the first digit, again denoted by the yellow arrow. There is again bony resorption of the tufts of the phalanges visible at the 2nd through 5th fingers, shown by the blue arrow. The bones are diffusely demineralized with more pronounced bone loss and a periarticular distribution, another example of which is pointed to by the white arrow. On the left is a PA radiograph of the left hand showing soft tissue calcification in the tips of the 1st and 3rd fingers. The yellow arrow shows an example in the first digit. There are also soft tissue calcifications at the ulnar aspect of the 2nd PIP joint, shown by the white arrow. There is bony resorption at the tufts of the phalanges at the 2nd, 4th, and 5th fingers, indicated by the blue arrow. There are also erosions in the ulnar styloid process, shown by the black arrow, and the distal radio-ulnar joint. On the right is a lateral radiograph of the left hand showing soft tissue calcifications in the tip of the 3rd finger, shown by the yellow arrow. The blue arrow again shows an example of bony resorption of the tufts of the phalanges at the 2nd, 4th, and 5th fingers. The final diagnosis for the patient in this case is scleroderma. The combination of periarticular osteopenia, acral osteolysis, and calcinosis circumscripta, which is localized soft tissue calcifications, predominantly around joints and at the tips of the digits, in multiple digits, is highly suggestive of scleroderma. Furthermore, erosive changes at the ulnar styloid process and at the distal radio-ulnar joint, as well as an elevated ESR, should alert the radiologist to an inflammatory arthropathy such as scleroderma. The top differential diagnosis to consider in this patient is hyperparathyroidism. Hyperparathyroidism may also present with acral osteolysis in multiple digits and diffuse bone demineralization. However, the classic distribution is subperiosteal bone resorption in the 2nd and 3rd digits, specifically the radial portion of the middle and proximal phalanges. This is not present in this case. Hyperparathyroidism may cause soft tissue calcification, but isolated involvement of the fingertips would be unusual and is a classic finding in scleroderma. Chondrocalcinosis may also be seen in hyperparathyroidism, but this is nonspecific. Since the patient has elevated inflammatory markers and a normal PTH level, hyperparathyroidism is essentially ruled out in this case. A second differential diagnosis to consider in this patient is dermatomyositis. Dermatomyositis may cause skin changes, elevated inflammatory markers, acral osteolysis, and soft tissue calcifications, which includes calcinosis circumscripta, but more commonly presents with calcinosis universalis, which is diffuse calcification of the skin, subcutaneous tissues, muscles, and tendons. These findings are not present in this case. Dermatomyositis may also be associated with scleroderma and would show findings of myositis on laboratory values, such as elevated CPK, elevated muscle-specific antibodies, such as anti-RNA and anti-MI2, and diffuse muscle edema on MRI. Although weakness is present in this case, no definitive myositis lab values are available to confirm the diagnosis. Take-home messages for this case include that scleroderma refers to a complex connective tissue disorder. It encompasses localized scleroderma and systemic sclerosis with its variants, limited systemic sclerosis, formerly CREST syndrome, and diffuse systemic sclerosis. X-rays in the hands can be useful to assess for arthropathy. Acral osteolysis can be seen in 16% of patients. Calcinosis circumscripta is seen in 46% of patients and may be found in periarticular and subcutaneous regions. Hand involvement seen with radiography may also include erosions, joint space narrowing, demineralization, and flexion contractures. The treatment and prognosis in these patients is dependent upon which features are present. Preventing these patients from microtrauma is important to avoid the soft tissue calcification.